Hi, it's Jenny B, NSWOC, back with our time series with infection. So I had to delete some of these if you'd seen them, so these are a bit of a repeat. However, I still want to go through Nerds and Stones. They cut off on the last video. So just we'll jump right into it again. Preaching from the Gospel of Gary Sibbald. These are actually something he created many moons ago to actually help us guide where we're going with a chronic wound, when we should be using antimicrobials, and then when antibiotics are actually indicated. So one of the first acronyms that he had created was NERDS. So it's for people like me that, you know, we love little acronyms and things to help jog our memory to maybe identify when we're doing a wound assessment what is actually going on within the wound. So if we have a wound that's been open for 6 weeks or more, for the most part we are considering those chronic. And to determine whether it's actually just a colonized wound, which is something that a topical antimicrobial can likely take care of, he has this little acronym. So N stands for non-healing, meaning that the wound again has really not changed in size. We do know that if a wound within 4 weeks has not reduced by 20%, it will likely not be healed by 12 weeks. So at the 4-week mark, it's much better if we make an intervention then instead of letting things continue down that path of non-healing. So if we have a wound that's non-healing, we have some erythema or exudate, large amounts or increased amounts of exudate that we're noting within the wound. That's usually a sign that there is some colonization and infection starting to occur. R stands for redness or erythema, and when it's greater than 2 centimeters around the wound base. So some redness is just inflammation, that's part of the inflammatory process, but when it's starting to advance or beyond that 2 centimeters around the wound, that's also another concerning factor. Now the D stands for debris, or there's slough or devitalized tissue within the wound, and then S, you're noting a smell. So normally if you have 3 of these or so, that's when we're actually saying yes, that's a wound, because sometimes things can just be non-healing, or sometimes things can just, there is slough in the base because that's how deep it was. But when we're seeing 3 of these, that's when we're really looking at wanting to use an antimicrobial. Depending on the depth of it, when there's depth, usually a gelling dressing is much better at improving granulation to make its way to the top. When something is a little bit more on the surface, that's when we can use some of our meshes, our silvers, they work for both, and they come in different forms. So you can go back and review some of those in the dressing categories. So again, when you're seeing NERDS or 3 of these in a wound, that's definitely a sign that we need to start using an antimicrobial. So stones is when a chronic wound is actually healing poorly as well. And again, there are signs of infection developing to become systemic. So this is when antibiotics orally often can be indicated. Sometimes, we do need to swab using our Levine technique, which again, I have a video on how to do those swabs cleanly so that we're getting the right bacteria out of the wound, not rubbing it on the old dead devitalized tissue. So again, his next acronym is STONIES or stones. So again, when the size is larger, so it's actually increased and gotten bigger. The temperature is increased by 3 degrees. So I often can check limbs with that. There are skin thermometers that you can use. A lot of our ones that we scan and that sense can actually tell us now. There are definitely skin thermometers we can purchase for your facility that actually can detect that as well. Os or bone. When you're seeing bone, there's actually it's an 86, but it's actually about 90% likelihood that there's osteomyelitis. If you're actually probing to bone, chances are there is infection right around it. So we tend to treat that. And we'll get a little bit more to that when we get to osteomyelitis. When there's new areas of breakdown, so you can actually have satellite lesions, and when there's infection localized that you're starting to get little erosions around the wound itself. So that's also a really good indication that there is infection. Again, you're seeing erythema and increased exudate. Again, that 2 centimeters around the wound, and that smell is ever present. So when you're having, again, 3 of these, that's a good sign that yes, we need to be doing a swab, and antibiotics are likely indicated. Sometimes physicians will give an oral dose of Keflex to start until they're able to get the sensitivities back, and then put them on the antibiotic that may be most suited for that type of infection. Then there's another one to notice when there's sepsis, because I've actually had this occur with patients that have developed abscess, developed other acute issues, and it's really great to recognize these signs early, especially if they have had a chronic wound. It is one good indication of when we're actually sending them to the emergency department, because they need treatment right away. So sepsis, again, when their temperature has been consistently above 38 degrees for at least a day, when they have an increased heart rate of 90 or so, or they have some hypotension accompanied with that, so where their blood pressure is low. They usually have an elevated white count. You wouldn't know until they got to the hospital. They can also have an increase in bands. That's usually something that gets the infectious disease guys a little riled up. So because the infection's spreading quickly and full out. Respiratory rates are usually above 20, and they have shortness of breath. Increased lactate of 2.0. Usually when you're getting over 3 or 4, that's when we're getting a little more concerned. Usually have elevated ESR and CRP, and these are definitely markers that we do like to have taken when a patient does have a chronic wound and they are presenting to the emerge. And then they can have rigors or chills, and actually they get an impending sense of doom where they actually feel like death is upon me. So it is because their body is reacting and need that to be able to be conveyed to others so that they can have their body looked at fairly quickly and infection addressed. They often have extreme pain and pallor, or they're very pale or discolored skin, and again, this often can happen when there is abscess formation, especially when they're very, very large. So again, to stop the abscess from continuing to cause systemic infection, we do need to do an irrigation and drainage, or an IND. So it does need to be opened up. That usually starts to reduce some of the symptoms. But again, there can be lots of other ongoing issues that are happening that, again, blood cultures and whatnot can reveal to what antibiotics need, and often they're needing IV when they're at this point. So that's my little blurb on infection. So again, when not to send to the emerge, when we need to just swab, and when it's best to try to intervene so that we can get these treated effectively and get these wounds closed, because the best wound is a closed wound. All right, stay tuned for some more infection in the next video.